Perfect. Well, hi, everybody. We're going to go ahead and get started. Welcome. We're very happy to have you here in our Better Together webinar. We are going to be talking about the how, the what, the why of health and housing data collection. So thank you for being here. Joey, if you can go to the next slide. Just a few technology reminders. You're currently muted. You're not automatically muted, so just make sure that unless there is something that you want to speak about, that you maintain your phones on mute. Sometimes that double mute is tricky. Also, you can use the chat to interact. You can, if you want to go ahead and just type your name and where you're from, something that you're excited that you might be able to learn today, just go ahead, use it, interact there. We encourage Q&A throughout the session, so please feel free to use that chat to ask questions. If you are having issues with just not being able to hear or just technical difficulties, you can also type that in the chat. I will be looking at that and just making sure that everybody has what they need. And you can also use the raise your hand function if you wanted to. Yeah, just a few technology reminders, but we are hoping that this is a fairly smooth, relaxed, very collaborative learning webinar. All right, so we'll go to the next slide. We are your presenters for today. My name is Joan Domenech, and I'm going to be kind of helping with the chat and just with some questions and as a support. I'll let kind of the rest of the panel present themselves. We'll start from left to right. Kendall.
Hi, everyone. My name is Kendall Clark. I'm the Director of Health and Wellness for St. James Social Service. I'm a board member for the National Health Care for the Homeless Council, and I sit on its National Consumer Advisory Board steering.
Great. I'm next, in alphabetical order at least. My name is Ian Costello, and I am a program manager for data analytics at the Corporation for Supportive Housing, CSH, and I'm located in Los Angeles, California.
Hey everybody, my name is Joseph Kinkel. I am a research associate with the National Healthcare for the Homeless Council on the implementation research team. I'm calling in today from Iowa City, Iowa. Good to be here with you all. And actually, this is me. So we're going to start today off with an interactive poll just to get a pulse on how everyone is feeling about data, also questions about where everybody is joining in from today. So we ask that you either use the QR code that's at the right hand of the screen, or I'm going to input a link into the chat for you all to use as well. So hopefully that link will bring you right to a poll. And as you do that, I'm going to bring up my slide to show the interactive. Okay, so we have some folks already responding. Great to see where everybody is calling in from. Looks pretty bi-coastal so far. Some folks in the center of the country, awesome. This is great for our discussion too, to have a diverse range of communities, different perspectives to add to our conversation today. So I'll just give a couple of minutes for each of these questions to make sure everyone has a chance to respond. We also know these dots are pretty big. It's hard to get exact. So if you want to include or type in the chat where you are calling in from, we'd love to see that as well. Okay, I'm going to go to the next question here, which asks, what type of organization do you represent? We know that we'll have definitely some federally qualified health centers on, maybe some housing focused organizations, government agencies, some case management, which is awesome. We'd love to hear your perspective on this webinar today. Some other national training and technical assistance partners, we love to see it. But a pretty good spread, and I think as we expected, a good representation of health centers on here. All right, so let's get into then our next question, which is about what your role is at your organization. Are you an administrator, a clinician, or a provider, maybe a case manager? Or maybe your role is more data specific as well. Quality improvement. Good, this is exciting. We love to see a good spread of different roles at different types of organizations. Okay, just one more second as the rest trickle in. We see in the chat we've got some community health workers on. Awesome. Okay, so now let's get into some more level setting around data. So how would you describe your organization's current internal data practices? Are you just beginning your journey and looking to improve in this area? Or maybe you've been doing this for a while and looking to take the next steps? Or as we see, some folks are actively using data for internal quality improvement and doing it well. Awesome. We look like we've got several that are in that rightmost category. So we'd love for you all to participate in our chat to hear what's going well at your organizations. And we should have plenty of time for that at the end of our presentation today. Okay, so on the other hand, how would you describe your organization's current external data practices? How you're using data to partner with other organizations or improve the way that you coordinate services with other organizations? Just beginning our journey. Few of you have been doing this work for a while, looking to take the next steps, but it looks like far fewer are doing this actively with partners for care coordination. All right, and I think we've got one or two more questions. And this one is more of an open response, and we'd love to hear what you have to say here of why is improving data practices important or relevant to your work? Or maybe in other words, why are you here today? What is important about this work to you all? To provide better patient care, definitely. Impact the community, enhancing health equity. See a lot about improving patient care, defining a scope of practice, understanding the gaps. These are awesome. Definitely areas that we hope to touch on today. All right, so we'll go on. I think we actually have one final one in this, which are, what are some of the barriers keeping you from doing this work well, from using your data more effectively internally or externally as an organization? I see Kirby in the chat says time, funding, staffing. Data sharing legalities, EMR or EHR functionality. Looks like a few of you said technology is a major limitation. So this is great. We are super thankful that you all are here today to talk about these things and that you're already open to share what's going on in your individual work and communities. And we hope that a lot of this is actually relevant. We touch on a lot of these areas today. So with that, I think, let's see here. Yes, that is the last question I had. So I'm going to go back to our presentation slides. And thank you all so much for participating in that to set our level. So I'm going to hand it, I think, back over to Joan, who is going to set the stage for the rest of our webinar.
All right. Well, thank you for that, Joan. Thank you everyone for participating in the poll. So just a little bit about what we'll be doing today. We're going to be talking about what are the existing data collection methods, how and why is data used at multiple levels, data and data sharing as a trauma-informed approach, and what is the role of consumers and their input to improve processes. So that's just a little bit to get us grounded and kind of what we're going to do today. But if you do have any questions that pop up or just something that you wanted to leave knowing today, we are here for that. So make sure that you use the chat and don't leave with those questions. I think this is Ian.
Yep. Thanks so much. So just a little bit more grounding. What we are setting out to do is to understand that data is an important tool, but it also can be a barrier. And I think, I'm really thankful for all the insight that you've been able to provide already. I'm very excited to go through this presentation because I think a lot of what you're seeing and what you're concerned about is the same things that we're concerned about and the same things that, we're touching on in this presentation today. Data sharing, is sort of central to this presentation as a way to coordinate care. We think that it can even be a way to reduce harm, and that data is not only a math tech highly technical quantifiable thing, but it also can be used to benefit people in ways that aren't as evident. We of course use data to understand from a systems perspective or a population, what's going on, but even individually and as a way at the point of care to understand the background of someone without them even having to, walk in the door necessarily. And I think COVID-19 has brought a lot of those things, telehealth and so on, to the fore about, people don't walk through doors that often anymore. And so data is important more now than ever. And at the same time that we're talking about data sharing and collection, I think we also need to hold space for patients being at the center, and making sure that they are the final decision makers about what happens to their own data, about what's being shared and to whom and for what, and that those things are specific and tailored to the organizations within a sharing network. Whether it's a health center internally, whether that's a collection of health centers with an HIE, for example, a health information exchange, or whether that's external to a healthcare setting into housing or other systems of care.
All right, well, I am going to start off our content today by talking a little bit about the social determinants of health, which most of you, if not all of you on the call today, have likely heard of, but really anyone that's interested in or providing services or solutions for folks experiencing homelessness have likely at least heard of and worked with the social determinants of health. And this is especially true for those of you on the call who mentioned being from federally qualified health centers, who are really at the forefront of providing quality healthcare services for folks experiencing homelessness, and who are really uniquely positioned to understand the factors in and out of the clinic setting that affect patient health and well-being. But again, the social determinants of health have been a part of our conversation for several years now in the health and homeless services sectors. So our purpose here is not really to provide an in-depth definition, but to establish a common language and to really talk about where data and the social determinants of health are connected, and where this conversation leads between data and social determinants of health. So briefly, what are the social determinants of health, or SDOH, as we'll refer to them moving forward? Well, the SDOH are the social, economic, and environmental factors that influence health and well-being of individuals and communities. So the SDOH are not only the conditions that really impact social needs and health outcomes and predict individual health outcomes of folks coming in and out of our organizations, such as an individual's housing status, an individual's income or education level, and individual's access to healthy foods, but also in a much broader and larger sense, the SDOH are contributors of broad health inequities at various community, regional, and national levels. So for example, communities' health in part relies on the availability of things like safe and affordable housing or housing programs like permanent supportive housing, accessible healthy food options, and more. So many of you on the call today who are direct care providers will likely be intimately familiar with how the social determinants of health are related to individual social needs. And because the nature of your work is really in assisting consumers and helping connect folks with resources and services that lead to improved health. And that's such crucial work. But also, on the other hand, we also know that actually addressing the social determinants of health head on really takes us as communities setting our sights upstream to change the conditions that lead to poorer health outcomes in our communities. So part of our hope, yeah.
No, I'm just saying, we as case managers and social workers are definitely key in this conversation when it deals, because we literally are on the front line, assessing the client for their social determinants. And so I think this will be a real good conversation for those caseworkers, social workers, peer advocates, peer navigators, and for those who with lived experience to be definitely a part of this conversation.
Yeah, thank you, Kendall. That's so true. And part of our hope today is to really explore how improved data and data partnerships are really crucial to work at all of these levels of social need and addressing social determinants of health as communities. So a little bit before we move on about where data and SDOH really overlap, many different types of providers, whether or not they consider their work related to SDOH or whether they call the types of information they collect SDOH data, they're really collecting and using data in really important ways. For example, when a housing program has documented a client's housing status, or a health center has identified whether a patient has access to health insurance, or outside of those two settings, a community-based food provider or food pantry notating food insecurity. These are all really important indicators and data points related to SDOH. So although these different types of providers are gathering this information every day to really meet unique needs of consumers, it is far less common, unfortunately, for organizations to coordinate with each other and talk to each other about the types of data points that not only they're already accessing, but also need to better serve their communities. So historically, even though health centers, housing programs, and other types of community-based providers are serving overlapping or common populations, they've really existed in their own silos without formal avenues of sharing information. So we hope that by improving the way that we talk as communities about SDOH data and how we can formalize partnerships in, of course, ways that are responsible, ethical, and also efficient, we can move towards a stronger continuum of healthcare providers that are informed by the social determinants of health and provide truly person-centered services. So let's talk about SDOH data and how it's actually collected and what that looks like in the health center setting. And importantly, how folks are already doing this in the health center setting. So as I alluded to in the previous slide, there's an enormous spectrum in how service providers are gathering data. And this is definitely true for health centers who really gather and use SDOH data in unique and different ways. So starting on the left-hand side of the spectrum, some health centers are gathering individual points of data for consumers in relatively simple ways, such as asking single questions or taking items off of intake forms. Some health centers have their own unique data tools that they've tailored to the work and the workflow of their agency. In the orange section here, some health centers are using state, regional, or locally mandated screening tools that have been offered by a state or public health entity. But more and more, as we move toward the advanced and the right side of the spectrum, we do see that health centers are focusing on advanced approaches to screening for SDOH with standardized tools or approaches that are integrated into workflow and often even in conjunction with health information technology resources that are available in the health center setting. So just briefly, a little bit about what we mean when we talk about standardized SDOH screening approaches. And this is not meant to go super in depth, so I hope this isn't overwhelming, but we show these 4 examples of SDOH screening tools that we know health centers are using and using successfully. Some of you on the call will likely be familiar with the one in the second column here, the Prepare tool, which we know a significant amount of health centers are using. But really, we show this to show that these types of screening tools can screen and tell us a lot of information in a single tool that ideally is limiting the amount of lift and the amount of questions that clients and consumers are repeating to different types of providers in and outside of the health center setting. So things like economic stability, education, food security, housing, these are all things that are asked in one place in these questionnaires. So if any of you on the call today are interested in learning more, we're happy to talk offline or provide you with resources and how to access these types of resources. So other standardized methods, taking a more formalized approach to screening for SDOH does not have to look like a long assessment. Some health centers have also found success in leveraging processes that already exist in their workflow or their services. Most relevantly, medical charts and diagnostic coding. So here on this slide, we talk a little bit about the Z codes, which are a subset of ICD-10 codes, which are the standard medical classification tool, which provides a really specific set of diagnostic coding that reflects and is related to the social determinants of health. So specific Z codes, which are from Z55 to Z65, are looking at persons with potential health hazards related to socioeconomics and psychosocial circumstances. So if used correctly and consistently, diagnostic coding like Z codes can provide a more comprehensive representation to clinicians and non-clinicians who utilize charts with information beyond the traditional clinical types of information, which can be a really useful tool to track social history, to track also population health across organizations. So this is a really useful and exciting tool that we see that is more of a practice that we see as emerging, and we hope to see more of in the future. So a little bit about the challenges to social determinants of health screening. We talked about some examples of approaches, but we definitely hear from health centers of challenges to implementing this type of work. First, in terms of workflow and capacity challenges. So health center staff often express capacity issues when new tools, requirements, or workflows are adopted in already stretched thin environments. So really looking at how we can limit the amount of lift there is really important. We know that screening is a sensitive process and can be a re-traumatizing process for folks with lived experience and folks coming in the health center setting. Some screening questions in particular can be re-traumatizing. So really considering who, how, and how often questions are asked plays a huge role in this. Trust and privacy concerns also, and health IT expenses is a really considerable challenge to implementing these types of practices as well. So we used this slide here as a sort of a transition to talk about how data is leveraged. So we understand that screening is something that a lot of health centers are doing and should be doing, but really it's important to realize that this process is only helpful when data is acted upon. We know that data is only as good as what we do with it. So if we collect forms that collect patient data, we want to make sure that we're using it. That's not just sitting in a file cabinet somewhere collecting dust. So we want to make sure that this is really useful and, again, calling back to some of what you all said in our poll at the beginning, is really helping us move forward in improving patient care and meeting real needs. So on that note, we'll take an opportunity to shift towards not how data can be screened for and collected, but rather how it's treated and leveraged. So I'll pass it back off to Ian.
Sure. Before going, Kendall, did you want to chime in as well? You have to unmute yourself, I think.
Yes, I was just thinking of a couple of slides back when you were talking about workflow and the capacity. When you're dealing with the workflow, you want to share as much information you can with your colleagues in order for you to service your client wholeheartedly. But I know some case managers, and I know some of you on the phone, experience what information can you share to help this client out? And is it just the name of the telephone number, or is it the entire file, which, we're not going to give a whole presentation on HIPAA, but, and like you said, are we doing it safely and correct? That data sharing, that was a concern of mine.
Yeah, thank you, Kendall. That is so important. And yeah, excited to get into that in upcoming sections too. So I'm going to pass it off to Ian, who's going to talk about data collection and uses.
Great, thanks so much. Next slide. So, so we talked a little bit about the kinds of data that are collected, SDOH, and I wanted to talk about how those data could be used, why they're important to be collected, and then maybe go into some of the myths or cultural mindsets that we have around data and data use that get in the way or could get in the way. So when we're talking about SDOH data being collected from health centers, I'd love to hear from you in the chat, or if you want to come off mute as well, is like, how is that data used? So to Joey's point, like, you collect all this information, and to Kendall's point, you want to help patients, you want to help clients. But if you're not doing anything with the data, then that doesn't really further the objective either. And so a common use of data, I'm sure, happens every day. Whether it's on a electronic, an EHR, EMR, or even paper files, you're using, how do I put this? Data doesn't have to necessarily be electronic to be data. A paper file is also data, right? But providers, doctors, nurses, other healthcare providers are using paper charts and electronic health records all the time, and that's data. And so you're using it at the point of care to understand a patient's history, understand treatment progress, diagnoses, outcomes. And so that's, probably one of the more straightforward and classic examples of how health centers use SDOH data. I argue, I maybe speak for others on the call as well, that more can be done. And so other things that can be done internal to an agency would be care coordination. So there was a note earlier about, and there was a quote from someone that we talked to around, the allergist doesn't necessarily need to know what the eye doctor says, or I can't remember what the other, but we operate in silos, and so the medical findings of one provider is irrelevant to another provider. And that's not so. I think that the SDOH theory, for lack of a better word, says that these things are interconnected. And so care coordination and using data as a pipeline to provide that coordination is really important, and is, I think, a really good use of data with internal to a health center. You don't even have to share with other health centers necessarily. Case conferencing and even intra-agency referrals, where you have maybe even non-medical related programming as part of your health center that don't need, to Kendall's point, doesn't need the whole file, but maybe they need a portion of it to help further a patient's outcome. So Kendall, I don't know if you want to talk a little bit about the food pantry program that your health center runs, and the interplay between the health side and the food pantry side. Oh, you may have to unmute. There you go.
Okay, I'm sorry.
No worries.
the organization I work for runs the food pantry. We have the largest food pantry in Essex County, but yet we have a lot of referrals come in. And when you're collecting all of this data from city agencies, from state agencies, you have to be careful on how you share it. Does our housing department, for a client who needs housing assistance, and we took a nutritional assessment for the food pantry, does all of that information need to be shared with the other department? And I think we need to be clear, and I'm quite sure some of the caseworkers and social workers on this call has experienced intra-agency referrals where they were limited with the type of data that they could share with another inter-department.
Yeah, that's a really good point, is that there may be policies or law that prevents you from sharing information, even though that information could help someone, could help your patient, and doing so could could expose the health center to risk legally. And so part of the conversation around data sharing later on, like this is going to be a topic that we're going to hit really hard on this conversation around data sharing and implications of that, is that it can be done, right? There are organizations that do it, and it's based off of sound policies, procedures, input from various stakeholders, and of course with patient consent, most importantly, that can allow for that sharing to happen. So yes, it's a good idea. Yes, it can be done, and has to be sort of undergirded by the boring paperwork and stuff that facilitate the entire conversation. Next slide, please. So thinking just a little bit, taking just a step back from what the health center does internally, and maybe looking outward a little bit about what are the implications, or what are the roles of a health center collecting SDOH, sort of, I put in scare quotes, non-health factors. Is that health centers, I don't need to tell this group, I'm sure, health centers are trusted institutions. You see clients and you see patients every day, and you help them every day. And that someone mentioned during one of the word clouds, trust, and I really had a moment, because that is something that is so huge, that I don't think that I think can be emphasized over and over again. I don't think you can overstate how important trust is, and we'll get into that in a second. And because of that trust, you may see patients that no other system sees. So we talk about the continuum of care and CES. CES is the coordinated entry system, or some communities say engagement system, and that is really just a stand-in for the homeless response system. So all the housing resources, or most, or if not all of the housing resources in a community, will flow through coordinated entry. Many health centers, I wonder, maybe some on the call, if you wouldn't mind putting in the chat if you are access points. You may do things like VI SPDATs or assessments. You may refer people to the coordinated entry system, or to housing partners. And for some patients, the important thing is that for some folks that you see, you may be their only point of care. And so being able to refer out to people that don't have your skills in terms of medical and healthcare, but you don't have necessarily their skills around housing, location, and services. And so so building a referral network. I saw someone, I swear I didn't make this example up on the spot just because you joined, but the well-rounded referral network. There's a colleague from HUD who works in kind of a lead hazard department, and my example for this well-rounded referral network is exactly that. There are environmental health implications that SDOH could collect on. Maybe there's lead or asbestos or whatever in a patient's apartment, and you can treat their health conditions, but you can't treat their lead. And so being able to go to, if they're renting and the obligation to change things, I'm not sure of all the rules, but it seems to me that it's incumbent upon the landlord to make a change. And if they're unwilling to do that, then what are the legal recourses that a patient has? And of course, a health center doesn't have that, but maybe they can partner with legal aid or legal services in the community that they can refer to. And then it affects their health, because if the lead is gone or the asbestos is gone, perhaps their health conditions related to respiratory or whatever the other things are that cause it could improve. And so by that measure, when we're talking about SDOH and the whole concept and framework, in my mind at least, and this is I'm not a medical provider, never have been, much respect to all of you that are, but it seems to me when you're looking at social determinants of health that these non-health factors, whether or not someone has, I mean, maybe lead is a little more direct, but employment, right? So whether or not someone's employed, whether or not someone's in housing, I think maybe it doesn't have ready impact on their health, but could further down the line. And so I argue that SDOH, these non-health factors, are health factors because they become so later on. Kendall, do you have anything? Sorry, I don't know if you.
Okay.
Oh, okay. Next slide, please. And so so internal to the health center, then we looked externally. Now taking even a step further back, looking at systems level data and what we might say is population health. And again, I'm really going to emphasize this point around system access, and particularly around CES, is that the health center sits at that health centers and healthcare in general as a system sit at the nexus of a variety of other systems, whether or not you know it. And so people that come into your health center may have involvement with the justice system, may have involvement with the homeless and healthcare system, may have involvement with other systems that are in the community. And by collecting on social determinants of health and understanding and aggregating all that information together, we get an idea of what's going on in the population and also what's going on with particular patients. And so that gets us down the road to resource prioritization and understanding how much lead exists in a community in housing, or how much asbestos, or what are environmental factors or societal factors that could impact health, and then thinking about, as a community across systems, what are the needed resources and services, not necessarily can be provided by the healthcare center, but are nevertheless needed in the community. How do we prepare for that as a coalition across different systems with partners in health and housing?
I think you made two. Ian, I think you made two very important points on the last slide and this side.
Yeah.
This lets you know how important caseworkers and social workers are, because once the medical part is being taken care of and the medical personnel are done with their job, and then they have some social determinants of health, homelessness, food need, utility assistance, this, that, and the third. This is where the social workers come in. And this is where what we do now, medical case managers, but all facilities don't have medical case managers, but they do have an intake person, and they do have that social worker who knows the resources in the area and can refer the client to the services that they need. But hindsight, this is where the data collection a question comes in. How much data can I share if I'm a doc or a medical case manager or a social worker? How much data can I share with the other agencies who's helping me with this client, with the lead or with the food or with and we have to keep in mind the levels, the privacy and the confidentiality of the client.
Yeah.
Where do we cross that line?
Yeah, great point. Yeah, absolutely. And that's actually, I'll transition there because that's a great point to transition on. So next slide, please. So that's where we're getting into data sharing, and the barriers that, Kendall, you articulated are just really, and I'm sure people can think of a million. We talked about this at the beginning when we were doing our first Menti poll, is that there's a number of systemic barriers that data present. Data is a tool. Data is an approach and something that can be helpful, but at the same time, data can be what stops us and holds us back. And just looking at from just a patient perspective, when someone comes in and they're asked to here fill this out. I don't, I'm sure the processes are varied from health center to health center, but the repetition of completing intake forms and assessments. What we heard, this is a direct, these are direct polls from focus groups that we did a year or two ago now, where people are just saying, there's too much data to collect. These are providers saying this as well. So you can imagine what a patient thinks. It's like, there's too much to collect. There's too many points at which we collect data, and there's too many people that want it. And that leads to patients. I can imagine. I mean, I'm a patient with my doctor and my dentist, and I fill things out all the time, and I'm frustrated by it. And I thankfully don't have, a history of homelessness or behavioral health issues that could be quite sensitive. And so the repetition of questions, particularly ones that touch on history and trauma, could really harm people. And so understanding how data can be a source of harm, I think is not something that is really thought of very much. And so that's one of the ideas as we were putting this thing together that I'm really focused in on is as someone who's interested in data and technology and how it can help. We have to be really focused in, and Kendall does a really nice job of calling attention to this, is that the patient is really at the center of all of this, and their consent and understanding of what is being done with the data is a way for us to approach data in a way that is trauma informed. And thinking this idea of data as a trauma informed tool, I think, is really interesting and something that we're hoping to really explore more. Next slide, please. And please, if any of this is resonating with you, definitely put it in the chat. We'd love to have a conversation, or feel free to come off mute if you have something pressing that you want to say as well. And so when we were thinking about data sharing, as we were putting this together, there's these aspects of data sharing that we thought are kind of do's and don'ts, right? And this is not an exhaustive list, but these were the core concepts of, like, we must do this if nothing else, and we must not do this if nothing else. And so I started with a very clunky definition of what data sharing is to me, and put that to the group, and this is kind of what shook out from that. And we think that data is done with consent, privacy, and trust. We can't, again, overstate these things, and that's why it's first. And that data sharing, and this is something that Kendall really brings to the fore as well, is that data sharing is specific. It has to pertain to the needs of the client and the services of the receiving provider, and that it's not about sharing when we think about data sharing, it's not about sharing everything all the time about everyone, but it's really about the relationships that you have as a health center and in a network with other services, with other health centers, which maybe you do share the whole file, and that's okay. But with outside providers from health, from housing, or from other services, it's maybe not necessary to share all of the diagnoses and all of the treatment history. But some things could be relevant, and you have to work that out beforehand. So it's not an all nothing proposition. It really is about a negotiation among a network of providers to understand what do I collect, what do you collect, and what's beneficial between us that we need to know about a particular person, and does that person consent to that? Are they okay with that? And then going from there. So it's a systemic approach, but it's not an all or nothing. Kendall?
And you also have to realize the clients are very resilient,
Yeah.
and they're very aggressive of what information of theirs that you share. And so one thing about it is you kept mentioning the word trust. If a client finds out that you shared some data that they didn't want shared, you miss that trust and you will lose that client. So we have to be cognizant of the clients and the level of privacy and confidentiality that they demand.
Yeah, for sure. And later on, we offer steps forward. So this isn't to make you feel hopeless or helpless, or that this is too hard. It is hard. It will be difficult, but there is a way forward. There are examples across the country of maybe even you have examples of data sharing that's happening. Next slide, please. So this is the kind of piece de resistance for me about trust, is that when we think about trust, I think oftentimes we're talking about patient trust in the provider and us. I think when it comes to data and data sharing, it is a huge leap of faith for everyone, for providers to have trust in their policies, for fellow providers to have trust in their other providers' policies, for us to have trust in the data of what's coming out and what's being collected, to have trust in the outcomes that we see from the data that tell us what direction we need to go and what policies are advancing the mission. And so without trust, and I think we need to broaden our definition of what trust is when we're talking about data collection and data sharing, because it isn't just that relationship, although it includes that relationship between the patient or client and the provider. And so to sort of so we maybe put out an optimal system of what does that look like when we have trust, and what does it look like when we do data sharing, and to get from here to there requires a cultural shift. And Joseph brought up a point around SDOH and Z codes, or during the SDOH portion around Z codes. And I've noticed just in my work working in the healthcare space across the country that Z codes are much more prevalent than they've ever been. People are really focused in on them. If I don't recall from the map if anyone's from Indiana, but we're working with a program at the state Department of Health for a rural grant that we're doing, and Z codes came up as something that they're really focused on collecting, and I thought that was really great, and that they've collected more Z code diagnoses than they've ever done before, and so we have to be kind of mindful about what that means, like from a data analytic standpoint. But it's great that we're even capturing them at all, because what I've noticed from service providers when you talk to them about, like, do you record Z codes? So oftentimes the response, you say, well, I can't treat housing instability. I can't treat their homelessness. I can treat their broken leg, but so why do I need to record this? What does it mean to me or the patient that I'm seeing, whether or not I put the Z code down? And I think it's important for us to look at that system level condition prevalence as well as access point role that health centers could have that shape a patient's social determinants of health later on by recording that. Because by recording that, maybe that goes to a referral, maybe that goes to the CES, and you can coordinate your care that way. I think some other points that these are sort of the myths or cliches that you hear a lot. Leadership not being bought in. This really does require a top-down approach, because the next one that lawyers will say no, and that's, I think, probably one of the number one. That and HIPAA are probably one of the number one, number two, depending, reasons why data sharing or data collection is a problem. And for at least the lawyers not to necessarily be too much, and apologies for any attorneys on the call, for the lawyers not to be the barrier. I think you really do need leadership to say, no, this is our direction, this is what we're going to do, and we're going to find a way to do it that's legal and the right thing to do. We're not going to break any laws, but the risk, and attorneys are doing their job. They're protecting the organization and limiting risk. But the benefits of data sharing, if it's done correctly and legally and securely and with permission, far outweigh the risk, I argue anyway, and I'm not an attorney, but that far outweigh the drawbacks. Next slide, please. And so it's just sort of as we were building this presentation, this sort of came up as part of it, and I tried to find all P words because we started with 3 Ps and then expanded to 5. And so this pyramid, another P word, of kind of where you can start, and these are the core elements of how data collection, data analysis, and policy, and data sharing work together, and that these 5 elements are necessary in concert with each other for having a successful data collection and data sharing apparatus. And so, they build off each other. Having good policies makes good process. Having good process makes good paperwork. Having good paperwork makes for a better patient experience, and a better patient experience makes for better performance and better outcomes.
And as
Oh, sorry, you got muted.
And as each one of these built on one or the other, it doesn't necessarily have to be in this order that you see it in. Some places start off with policy first, and then it builds on to performance or patient experience, and then it builds on to policy. So it's a good way to start. These are great P's, but you don't necessarily have to start in that order.
Yeah, no, yeah, for sure. I think particularly policy can be really cumbersome, and so that in and of itself, I think, is enough to turn people off. But I think if you can start anywhere, even with the patient experience, I think that is a really low hanging fruit to talk to people that are going through the program and understanding what is your experience here, how can we make it better. So I completely agree, absolutely. Next slide. So these are some of the things. These are some quick recommendations that I think you can take steps to start addressing those elements that we talked about. And if you want to start with policies, then what policies does your organization have? What are the procedures that you have to share data? What's being collected? And if not what's going on in your agency, what's going on in the community? What are the data sharing processes that are happening that you're not party to, and are they working? Could they work for you? How do you talk with them to maybe open a dialogue? And that's not to say that you're going to go from not talking to data sharing in a week, but I think you can explore what those options look like. And HIPAA is a constant sort of shadow over this whole conversation, and it's an important conversation to have about it. So you really need to know the ins and outs, and what are your obligations for your agency and for you personally. There's thank you very much for the conversation that's going on in the chat right now about mandated reporting, and I think HIPAA is law. Being a mandated reporter is a legal thing that there's really no way around it. That's why it's law. So HIPAA being a law, the organizations that are covered entities that have obligations need to follow them. But that doesn't mean that all data is shut off. There are plenty of organizations that are covered entities that share data, but they have to do it with the set policies in place, with the paperwork, with the consent of the patient. And so that's kind of another myth about data sharing, where we're HIPAA, so never mind. Next slide, please. And so I think we're going to transition again into the role that consumers and people with lived expertise have when it comes to data and data sharing. And so this quote, I think, is really germane to that conversation. And the highlighted bit at the end is really what does it for me, is that people don't know much about me, Ian, that I go to the doctor and dentist and so on, and I fill out paperwork, and I don't think that they know as much about me that maybe some patients going through health centers or certainly people going through the CES system know about, are known about. So there's more information about other people that are in need of resources and services than about me. And so that, I think, working with people's data every day is something that I think we have an ethical, moral obligation, more so than I think in other settings, to treat data and to treat consent as paramount, because there are folks that are extremely vulnerable going through these systems, and could have terrible consequences.
Well, we know that HIPAA already has certain regulations in place, but I think this slide goes more to what is your HCH or your healthcare center site policies on data sharing, with the respect of client privacy and confidentiality. What is your, I'm speaking to everyone, on the call, what is your agency's policy on data sharing while respecting client privacy and confidentiality?
Yeah, for sure. Next slide, please. And next. Oh, there we go. So I'm just going to set this up, and then Kendall, I'd love your input on it as well. But I'm a huge fan of the NCAB, of the National Consumer Advisory Board. A few years ago now, the advisory board manual was released from the council, and I really like it. If you have to read it, I don't know what to say. It's required reading, and I really like the model. And I think one of the other aspects that came out around consumer input and lived expertise is this question that was posed to me personally by someone with lived expertise and a few other colleagues about how do you know what I need? And even blowing right past what do I want? Like, what do I need? And I thought that was a really powerful thought, because a response like, well, I've got all this data that tells me, that's not a good response. It's of course, well, I ask you, what do you want? What do you need? So I think the NCAP is just a wonderful model. And Kendall, I would love your take on it. You have to unmute.
Okay, so as some of you can see that I am a member of NCAD for the Healthcare for the Homeless Council. I think, and I'm going to speak on as me being on the board of governors for our health centers here in North. I see that people who lived experience or people who attend that clinic is crucial in the direction of which that clinic needs to go. Now, we're not changing medical policies. We're not changing that kind of policy, but we are changing welcoming policies. We are changing, respect and privacy and confidentiality. We do have that box in the lobby, the comment box, and we take it to heart when we sit down and we review those comments. We make sure that the client or the patient is represented while we're discussing the HCH's policies. NCAB, any community advisory board is very important. And as some of you know, HRSA demands are 51%, 49% people with lived experience on those kind of boards. So that's very important, because we can tell you what's the situation is from the heart. One of the things that we were doing, we did a consumer participation survey where we were talking about the security of your HCH. And we came to find out that what we found was that there were some areas in the clinic that didn't have, in view of the camera, there was some hidden and non-traditional places. And so we did our best to correct that, and it's fully corrected. So consumer input is very important.
And so as we're kind of taking us toward the question and answer portion, there's just some other things to keep in mind around how people with lived expertise or current former patients have a role in process and policy, not only around data, but I think other operational things that happen around a health center in community. And I think that there are that consumer input, it's important to collect everywhere, and not just in anonymous comment cards, in the lobby, although that's important, but also just very intentional. We talked about the Consumer Advocacy Board as a model around providing a forum and specific decision-making power for consumers around facets of the health center that impact them. As well as periodic reviews of policy, of paperwork, to look for, this concept of plain language is is something that's really important to the federal government, I think you can go to like plainlanguage.org or .gov rather, for what plain language means for the federal government. But just in general, like, are we writing paperwork? Are we putting forms together for other attorneys? Or is it really targeted, and is the audience really the patients that are coming through? And how do we know? Well, let's ask and see what could be better. That's not to say that we don't include things that are required by law, but can they be framed in a way that are more easily understood? Or is there a process by which we can help folks if they have questions? And then the next thing, and this came up during our chats around developing this webinar, is that oftentimes well, I need to run this by our attorney, I need to run this by our executive, I need to do this, I need to do that. And I think as part of that, like running it up the chain, that process should include your CAB, should include people with expertise. The same forms that you put in front of your attorney, consider whether or not they should be put in front of patients and ask them what they think. And that, I think, and I know this is sad, I know this is perhaps self-evident, but and it's just one of those things that you just say all the time, and I'm going to say it again, is that trauma-informed care doesn't start further down the line. Trauma-informed care starts at the front door. It starts with the lobby. It starts with the person who's answering the phone. Even though they're probably not a social worker by trade, but that doesn't matter. Like I'm not either. And in my previous capacity, I had to be ready to answer the phone and have someone in crisis and know what to do and how to manage that. And so I think it's really important to be mindful that our paperwork has to be trauma informed too, and data has the capacity to be trauma informed. Great. So I'll pass it back.
Yeah, so we wanted to make sure we had an opportunity to give you all space to reflect on what we talked about so far, and hopefully this can stoke some further conversation as well. But this is going to use the same link as before to bring you to the Mentimeter, just to give a few reflection questions. So I'll just give you a second and I'll pull this back up from what we had before. All right, so some follow-up questions for you all. So given our conversation so far, especially hearing from Ian and Kendall from his personal perspective as well, how do you hope to improve the way you use data in your health center or in your organization looking forward into the future?
Joe, can you resend that link for this, because it's like 100 questions ago.
Yeah, good point, Kendall. Here it is in the chat now. Someone said make data more available, or make more data available. Just give a couple seconds for folks. Advocate for standardized social needs assessments, put data sharing agreements in place, creating workflows to ensure follow-up. Someone said being mindful of how we collect data and use that to integrate into patient care. Comb through data more intentionally. I like this piece of only collecting what we need and have a plan to use it. Yes, I like let staff know the impact of data, really getting to that staff buy-in piece. I love it. All right, let's move on to the next question. What parts of the presentation resonated with you all in terms of data partnerships, whether it be improving the way that we connect with other organizations in terms of data, or this can also mean some internal data partnerships too. How do we partner with other parts of our organizations to use data better and more effectively? know these free write ones take a little bit longer than the multiple choice questions.
I was just gonna think that everyone's just stunned.
Let me just take a couple seconds here. Need to share data with community partners. Sure.
Yeah.
Focusing on client trust is most important. And I see that as being before actually sharing the data, before getting the structure in place to share data. Focusing on client trust is most important. I'd love to see that. Ensuring data collection is trauma-informed, working with CABs. I think you all are seeing the future, because the next question is specific to consumer leadership and consumer involvement. So you all have already alluded to the fact that you're thinking about the importance of consumer input in data, but I'd love to hear if any of you resonated with any specific parts of what we talked about, or what Kendall shared about the consumer advocacy and NCAB model. This is also a good point too. If anybody would like to come off mute, we'd love to hear from you too. Somebody in the chat said, try to keep following the clients. A great reminder to check with our customers. There must be consumer involvement in HCH decision making. Great point. Really across the board, right? All important decisions that are really ultimately going to affect folks that are receiving services, including data. There needs to be consumer involvement. Someone said in their organization, they ask their CAB about data collection, but need to do better about asking youth at our school-based health centers. Great. That's a great point. I'd love if that person who said that is comfortable. We'd love to hear from you, to hear how that process is going of engaging your CAB about data collection, if you feel comfortable.
Hi, sure.
Hi.
We've brought various forms to our CAB and asked them to give feedback on if it's clear, if they feel like, you know, sitting in the waiting room, if they would feel comfortable filling it out, or if they would feel more comfortable filling it out in a room or with a medical assistant support and that sort of thing. And years ago, we asked our school-based youth at our school-based health centers about some of the forms, but it gets particularly complicated because there's so much surveying happening for youth because of all these there's like the school-based health center, and then there's the school district, and then there's like all these people that want information from them. And so it's been particularly challenging to collaborate with all these people that are wanting data, and youth who, for, you know, absolutely deserve their privacy. So that's been particularly challenging for us to find a balance.
Rachel, would you mind sharing your community? Where are you from?
Yeah, we're in Oakland, California.
Oh, right. Nice.
Yeah. And we have a very unusual FQHC that is part of Children's Hospital Oakland. And so we have a primarily pediatric population, and we serve up to age 24, and then refer to other FQHCs in the community. And then also have 2 school-based health centers in high schools in Oakland. So, and I think that's another challenge that we have, that a lot of the data that we're collecting is from caregivers of pediatric patients. And so there's some dynamics that go with that. But I've really appreciated this presentation. Thank you.
So Rachel, when you speak on the subject of unusual FQHCs, our FQHC in the city of Newark is run by the municipality, it's run by City Hall. And there's different layers now of data sharing authorizations that goes on. And I want to be careful not to make that, being that we're associated with municipality, make that a barrier when it comes to gathering data or getting the information that you need for clients.
Thank you.
Thank you so much for that. I think this is a great spot. This is, I think, the last question I had anyways. So we'd love to open it up for maybe just a few minutes before we wrap up to see if anybody else would like to come off mute or have any questions. We have
if you want to advance the slide one more time, there's, I think, just one last, there you go.
Oh, great.
So much.
Perfect.
And then also we have another poll, but in Zoom, and this is for our HRSA objective. So Kathy, who is our amazing support, if you wouldn't mind just answering those questions that she put up, and they're reasonably anonymous. But feel free to, you know, be honest about how you feel. Great. And then, of course, if you have questions, yeah, definitely feel free to come off mute or put them in the chat. But we're at the end of our presentation, so definitely want to extend a huge thanks to all of you for coming, and also my co-presenters, Joan, Joey, and Kendall. Thank you so much for all of your work and advice putting it together. Yeah, thank you.
We're open for any questions, chat or verbal.
Great. Well, seeing none, I think we can probably stop the recording here, and I'll just say thank you one more time to everyone for coming, and the great engagement that we had in the chat and along the way.